All right, Dr. Forman and Weaver, I think we can sign back on now.
You got it. All right. Oh, wow, you got a lot of attendees all of a sudden.
Yeah, we have 50, it looks like.
That's very nice. Good, good, good.
I think we're expecting over 100, and I'm sure they'll trickle in as we get started here. But
All right.
Since we're just doing the introductory remarks, I'm going to go ahead and get started, if that's okay with you.
It's great.
I hear a little bit of an echo of my voice. Does someone maybe have my YouTube video on or something? Oh, I think it's me, actually. Sorry about that. Okay. Good afternoon again, everyone. My name is Kobe Rizik, and I'm the president of the Buckley program. I also want to, hopefully everyone can see Weaver Lilly here, our vice president, who will be co-hosting this event with me. Welcome to this Zoom conversation on COVID-19 with Professor Howard Forman of Yale. We look forward to discussing this public health crisis and all its complexity with one of our nation's top public health experts. Before I introduce, actually, Weaver is going to introduce Professor Forman formally. I want to say a few quick words about the Buckley program. First, for those of you who don't know, the William F. Buckley Jr. program is an organization dedicated to promoting intellectual diversity and open political discussion at Yale. We do so in a variety of ways, including hosting lectures, dinner seminars, firing line debates, and an annual conference. Our over 300 Buckley Fellows have a wide range of political beliefs, from the left to the right, but they all stand united against the formation of a liberal-only echo chamber on campus. By providing Yale students with a forum to engage meaningfully with serious conservative thought, the Buckley program forwards its mission of a more open and more representative political atmosphere, especially at a university where the mission is the cultivation and creation of new knowledge. Buckley Fellows believe that all perspectives, including those of the right, must be heard and examined in good faith. You can learn more about the Buckley program as well as how to become a Buckley Fellow on our website, buckleyprogram.com. The deadline to become a fellow this semester is today, so get those applications in. All Yale undergraduate and graduate students are eligible to become fellows. If you're a fellow, please do us a favor and share this opportunity with anyone who you think may be interested. At this point, I will hand it over to our Vice President, Weaver.
Yeah, so I'm honored to introduce Professor Forman for this conversation on the coronavirus today. He is a professor of diagnostic radiology, public health, economics, and management. He directs the healthcare management program in the Yale School of Public Health and teaches healthcare economics at Yale College. He's the founder and director of the MD MBA program, as well as a faculty director of the healthcare focus area in the School of Management's MBA program, MBA for Executives program. As a practicing emergency radiologist, he is actively involved in patient care issues, and his research has been focused on improving imaging services delivery through better access to information. He has worked as a health policy fellow as well in the United States Senate. So we'll spend the first 10 to 15 minutes on questions from Kobe and myself, and then we'll move right into questions from the audience. So if you're watching, you can either hit the Q&A button below on the bottom of your screen and type in a question anonymously, or you can hit the raise hand button and we'll unmute you to have you deliver your question in person. And we'll do our best to wrap up in an hour at 5:30. So without further ado, I'll move on to some of our, to the first question here. So Kobe and I were wondering, this virus came about, it really took hold of our lives about a month ago. People are now, talking about the chaotic month of March and what's to come in April. So just looking backwards, what are some important lessons we can learn from what happened in South Korea, Italy, China, Spain, and other countries, and what that means, countries where the virus is starting to slow, what does that mean for us, and what are some lessons we can learn from countries where this is where this occurred previously?
I think in some ways that we've become so accustomed to American exceptionalism in all its manners that we assume that when something struck in Wuhan and then in Daegu in South Korea, that if they were able to manage this, that we were going to be able to manage this. And I think separately, we also assume that we would not be able to take the authoritarian measures that China would take, and that our citizenry would not tolerate that as well. And so we sort of hung back for a long time, expecting that various parts of the US government were going to step in and somehow prevent this from taking root in the United States. And I will say I include myself among them, where I really believe that even if we didn't see it visibly, that there were measures being taken by our CDC, by even parts of our military and domestic protection apparatus that were going to prevent further spread. And it turned out that we really were not nearly as well prepared as we could have been. And we've lost a lot of precious time compared with those nations. On the flip side of that, I will say that if you would have asked any of us 6 weeks ago if the United States could tolerate the level of lockdown that we pretty much have right now in this country, whether through actual force of government or just through custom change, most people would have said impossible, can't imagine it. And yet we have seen a dramatic change. And that has been one of the few things that I think is going to help us through this.
Great. I'm curious, kind of along the same lines in comparison to testing and what other countries have done with testing. We've certainly not quite where we need to be, but we've ramped it up a lot in the past few weeks. How useful is the metric? How useful of a metric is just the number of confirmed cases comparing from country to country? Like fewer confirmed cases doesn't necessarily obviously mean less cases from an objective standpoint. And now, is it correct that the US has tested more people than other countries at this point? How do we go about kind of reconciling? How are we to compare country to country when the procedures that have been in place around testing haven't been the same?
Right. So a few things. Let me just take one quick step back and say that my colleague at the School of Management, Ed Kaplan, wrote a really great piece like 6 or 7 weeks ago, where he did a mathematical model, which basically said, if you can find every case quickly and find them efficiently, and then do contact tracing and quarantine and isolation of both the individuals who are infected as well as their contacts, you could stamp this out. And to this day, he still believes that, and I believe he's right. But our ability to conduct testing has dramatically lagged our need to do testing. So we, at this point, probably need to be testing about 1 million people a day, and we're testing somewhere in the low 100,000 a day range. And up until a few days ago, we were testing way, way, way below that. So in total, up until yesterday, we had tested probably 1 million, maybe a little more because we're not counting all the negative tests in some of the private labs, but we tested a total of 1 million in this country as of a few days ago. And we need to be testing probably 1 million every day right now, if not more than that. So we're grossly lagging testing. You raise a really important point, though, which is that if you aggressively test, like they're doing in New York, for instance, you're going to have far higher case finding, and your numbers look bad earlier, which is something that I think people are afraid of. Like some states, honestly, I believe, are afraid of aggressively testing because once they test, they're going to have big numbers, and then they're going to look like a big target for why they didn't do something earlier when those numbers come out. It's very easy to hide cases, because if you don't test, you don't find, and if you don't find, nobody has to know, theoretically. Although eventually actual cases convert into deaths, particularly if your population is older and sicker. And so what we're finding in some parts of the country, like Michigan, Louisiana right now, is higher case fatality rates, or what we call crude case fatality rates, since we don't know the actual case fatality rate. We're finding those rates are higher and higher and higher. And when you see high crude case fatality rates, it indicates that you're only finding the sickest individuals because you're not testing enough. And so New York State, despite having an immense number of cases, has a lower case fatality rate. And states like Louisiana, Michigan, and Washington State at the beginning had much higher case fatality rates. But eventually the truth comes out. And the other thing to mention about that is deaths are hard to find, but they're not impossible to hide, but they're not impossible to hide. A lot of old people every day in this country die of pneumonia. So when an old person dies of pneumonia in a hospital or outside of a hospital without having been tested, they are not a COVID death unless somebody certifies them that, and that's typically with a posthumous test. So it's only when the numbers get really big, which they're starting to now, that it's harder and harder to hide your COVID deaths.
Thank you.
So up until about a week ago, the United Kingdom had a very interesting strategy. They were a bit of an outlier in their approach to the virus, where they tried to develop rapid herd immunity. They abandoned that maybe a week ago or so. Could you talk us through the reasoning behind that strategy, what assumptions went into it, and then the decision to adopt, what we're doing now, the extreme social distancing?
Yeah, so the problem that I think a lot of people miss when they think about what we're facing now is the healthcare system and how it overtaxes it. And, I don't know where, the majority of people watching today are watching from, but when you're looking at New York on TV, or as I am living in New Haven and seeing how we're managing it at New Haven health system, you realize just how quickly this overtakes your own healthcare delivery system. So if you take a strategy of sort of, I'm just going to let it happen, we're going to get to a high degree of prevalence in the population, we're going to do everything we can to protect elderly people, and we'll get through this somehow, what you find is that you overwhelm the healthcare system to such a degree that you ultimately will find harm coming to your typical patient with an emergency surgery need, with a heart attack, with a stroke, with a trauma. Those patients will actually find themselves further harmed than if they were, during a more normal time. So it's not just the mortality, fatality associated with COVID right now, but there are spillover effects from overwhelming the healthcare system. And I think the UK came to very quickly realize that there was no way to get around that process if you didn't go to an aggressive social distancing lockdown scenario. And I think that's where we are right now in most parts of the country, is that recognition that there's almost nothing you can do to avoid going through this incredible spiky period where it will overwhelm all of your systems, and not just hospital systems, by the way, but EMS, police, fire, and so on. So it's an incredibly burdensome wave that's coming through all of these regions. And I think we're starting to see a little bit of a turn in places like New York. We've seen a little bit of a turn happen in Italy, and certainly South Korea and China are the models for how to sort of tamp this down as fast as possible.
Thank you. Kind of in the area of testing more, and totally correct me if I'm wrong, it seems that at least in the arena of COVID-19 testing, that recently private testing facilities and private industry has been able to be faster and generally more efficient than government agencies, at least in some states. What does this say about the larger question of how capable our government can be in a crisis like this? And what does this say about perhaps giving more control for those who might say, how is this evidence that we should give more control of our healthcare system to the government when it seems that private actors are able to be more successful in testing, at least right now?
Yeah, so no, it's a great question. I think it's a great point. So first of all, you have to recognize that the role of our central federal government, and particularly the CDC and let's say FEMA, should be about coordination, should be about direction, it should be about communication. We do have state laboratories in every state. Some are better than others. And when you talk about private labs stepping up, I would also point out that many of those, quote, private labs are hospital labs and university labs. And so probably one of the most successful quick startups was the University of Washington Virology Lab, which has consistently had a very high testing capacity for, I can't even keep track anymore, but 5 or 6 weeks. So I agree with you that the private sector has stepped in. There are several ways in which the private sector is now stepping in. At first, it was standing up these private labs in hospitals. Second, it was standing up labs inside private entities like Quest and LabCorp. Third, it was companies like Abbott moving to market very quickly with testing that can be done inside these private and hospital-based laboratories. And then there's the reagent issue, which is the raw materials are mostly provided by the private sector, and we're still dramatically in short supply of those things. And this is not, in my opinion, necessarily a failure of the private market, but this is a failure of coordination that we could have done at the federal level. If we would have been doing as good at modeling at the federal level and looking out there and saying, where are we going to need the reagents, the swabs, where are we going to need the test kits delivered at this stage and at that stage? Why does California, for instance, have 59,000 tests that have been performed but not run through? So we have no results on those tests right now. There's so many layers of problems here. And then there's sort of the federal coordination piece, which, interestingly enough, the private market is stepping in here as well. And there's no question that we have enormous innovation. We have a very entrepreneurial spirit in this country. So the COVID tracking project is run by a small group of people that I think make most of their money generally off of writing for The Atlantic. That's not an entrepreneurial entity. That's an entity that took it upon themselves to track testing across the country. We have no way to track across the country hospitalization rates, ICU occupancy rates. Where do the ventilators need to be? Where should they be? So we can get responses from private industry with or without perhaps the Defense Production Act, but you still must rely on coordination at the federal level if you're going to see that be successful. Otherwise, what you have right now, are many states competing with one another, and if anything, driving up prices in a non-market situation so that gouging is going on around things like ventilators, personal protective equipment, and even reagents.
Thank you,
Professor.
So recently, 2 models came out of universities in the UK, one from Imperial College that showed a doomsday-like scenario of a couple million deaths worldwide, and one out of Oxford that was a lot more conservative in its estimates of how many people would contract and die from the virus. So could you talk about the assumptions that go into the models that have given very different results, and which ones ultimately you think are more statistically accurate?
I think they're actually the same. They're basically the same models, just revised, but maybe there are 2 separate models. So first of all, the model that we're using in the United States right now that everybody keeps looking at in the University of Washington, sponsored by the Gates Foundation, is a model that is built up saying that our pattern of deaths is going to replicate that of Wuhan, and that if we just take Wuhan's curve and apply it here, it will tell us a lot about what we look at. It's not a traditional epidemic model. It's basically a best fit model of what happened in Wuhan. What do we think it's going to look like in the United States? Everybody is speculating. There is nobody out there who knows what's coming next. All we can do is speculate based on the best information available to us. Let me give you an idea of the things that we don't know right now and for which there is rampant speculation in various directions. We don't know, for instance, what % of the population is already recovered from this virus. One of the reasons we don't know that is we fell so far behind in testing that we don't know whether 10 million people have already been exposed, recovered, and now have antibodies, or if it's 1 million or even less than that. We don't know whether the virus is spreading to children as much as to adults, and whether children are as likely to spread it as adults. Okay, we don't know whether individuals are going to be by social distancing alone that we can reduce the R0 below 1, or whether we can just get it down below between the 1 and 2 levels so that at least we slow the growth that's going on. There's a lot of unknowns that exist right now. In general, I think that we are going to have continued explosion of cases in a lot of parts of the country. We're just seeing the tip of the iceberg in the United States, and in areas like New York State, I have more confidence that we're seeing actual numbers than I am in a lot of other parts of the country. Once testing gets more aggressive, we'll have a little bit more feedback on that. But rest assured that when you see all these models that either are doomsday models or models that are assuming that we've already somehow passed into a herd immunity phase, that is not the case. We don't know enough to be able to answer any of those questions.
Great, thank you, Professor. I just wanted to remind all the attendees that we're now going to move into the audience question phase. So if you want to raise your hand and ask the question yourself, go ahead and do that, and we'll do our best to get to all the questions, and we'll unmute you. But if your hand is up and we haven't called on you yet, just keep it up, and like I said, we'll do our best to get to you. I did want to start out with one of our written questions that had been submitted to us in the Q&A, kind of getting back to the question of transmission, and I'm curious to know, as a public health expert, what you think about, and I guess it's not official yet, but this kind of rumor going around that the CDC is considering reversing its guidelines on mask usage and might ask that all people use a mask. If this were to happen, do you think that this might result in more people leaving their home and increasing exposure and maybe bringing that R naught of the virus up? And just generally, do you think that the reversal on the masks would be a good idea?
So the controversy around the masks is mostly about not taking masks away from healthcare providers and therefore putting them in a more defenseless position. So that's been where the controversy comes from. I have said consistently when people have asked me this, that I don't think that masks can ever hurt. They probably can help. They help partly because they can stop you from touching your face so much. And a lot of people do think that that's one of the ways to transmit. That's the only way in which I can imagine they actually help you. I don't think it's because you're breathing through a mask. A surgical mask is not an N95 respirator, and therefore it's really not going to prevent either aerosol or even droplets from sneaking in under the mask. It's not sealed to your face. But masks also serve a couple of other purposes. One is that they prevent you from spitting on other people, and that is a definite means in which you can be transmitting, spitting on structures around you, coughing, whatever, however you want to think about it. A mask can stop that. It also can be an important signal, I think, to others that you're taking things more seriously, and it may calm people in a certain counterintuitive way that, rather than, I think a month ago, if everybody was wearing a mask, it would scare people. Right now, I think if you saw more people wearing masks, it may comfort you to that you're going to have a lower likelihood that someone's going to transmit it to you. I think that the compromise that hopefully will come out of the CDC or another agency that seems to be one that people can come around to is don't wear surgical masks, but wear something on your face, whether it's a homemade mask or whether it's a bandana or a scarf or whatever. Anything that you do to cover your face and nose has the potential to reduce your ability to transmit to other people. If it doesn't reduce it, it's not making it worse. So it's sort of a costless effort, and it may make people feel that they're at least doing something.
Sure.
So there are a couple questions submitted from the audience that I'll combine into one. A lot of people want to know about the different drugs that have been discussed. So hydroxychloroquine is one, Z-Pak another, anti-malaria drugs that have been tried in hospitals. What is your experience with these? How should we parse the information that people are getting about these drugs, and what else could we possibly look towards?
Yeah, so the hydroxychloroquine is a special case because this is a drug that is in use already for patients with rheumatoid arthritis and lupus. It is a necessary drug for patients that have those conditions, and it is incredibly important that those patients have access to those drugs, and therefore it would be irresponsible for us to recommend to anybody that this could be a preventative treatment for COVID-19 when we absolutely have no evidence of that. As far as I know, as of this moment, there are 2 trials. One has demonstrated no effect, and the other trial may have an effect, but it also was such small numbers, and they removed certain patients that may have biased the results in a favorable way. If it works at all, it almost certainly works late in the course of the disease, during sort of the cytokine storm phase, when your own body's response to the viral particles is causing damage to blood cells and the lung. And that's how sort of the antimalarial qualities of hydroxychloroquine may be playing in and helping here. To use it as a preventive treatment almost certainly would have, even at a tiny risk on an individual basis, on a population level basis, may have substantial risk for people, because it is known to lengthen the QT interval in patients with certain cardiac anomalies and can lead to fatal arrhythmias. It can have interactions with low potassium levels, leading to problems there. And so it's really important that people do not just necessarily start taking a drug just because a rumor is that it might be able to work. I don't think there's any type of conspiracy about treatments right now. I personally feel like I'm pretty well informed, and I have no impulse to try hydroxychloroquine or azithromycin or any other drugs that are out there right now, because there's absolutely nothing compelling that I'm aware of that helps. But we have a couple of hundred trials in process right now, some that are relatively early stage in terms of disease, trying to see how you can modify the disease before it becomes severe. And then lots of other trials that are going on right now inside hospitals on patients that are hospitalized on COVID units and in the ICUs, to see what the effect is there. And so not only are we trying to suppress cases now in order to take off demand on the healthcare system and try to protect people from having infections, but we're also buying time to allow these trials to continue, so that perhaps in 2, 3, 4 months, we might have a better way of managing this illness, since we know that a vaccine is probably 8 or 9 months away.
Great, thank you, Professor. And I wanted to ask, in the vein of global cooperation, as someone who's been in the field for a while, how do you think that global cooperation on the coronavirus crisis compares to that of previous outbreaks, such as maybe bird flu, H1N1, Ebola, even SARS?
This is the first time that we've really had something hit our shores in a major way. I mean, Ebola, we sort of got away with. We had a few cases, we managed it. There are a lot of special features of that that are very different from the coronavirus. This is something that really hit our shores in the same way that 9/11 was the first time in my lifetime, in most people's lifetime, that we really felt that there was a direct threat on the United States. And I think that a lot of our hubris from having avoided this in the past hurt us. I think we really, and I include myself in this, I think we underestimated how bad this was going to be. And I think that, we very early on had people reaching out from China and Korea offering help, giving us advice. And I think early on we were pretty much afraid of taking that advice, because it might undermine our ability to be, seen as, the leader of the free world.
Great, thank you. Weaver, did you maybe want to do one of our in-person questions?
Another question that we have here is about, looking a year from now, year and a half from now, when this is really behind us, what is the public health system and the healthcare industry in the US going to look like? Is this going to lead to a lot of restructuring, or are we just going to kind of go back to the status quo? And what do you think it should look like?
Yeah, I think that the reflexive response to this is that we need to invest more in our healthcare facilities, that we need to invest more in our public health infrastructure. And that may be the right outcome. I don't know. I do think that much of the failure has not been the healthcare system and has not been the public health infrastructure on the ground. It was a failure at the beginning of leadership. And I don't mean this in a political way, but somehow our CDC, our warning systems, all the things that we normally rely on to set things in motion in what would have been December and January and late January, that should have had us in a position of extraordinary alertness and responsiveness in late February, completely failed us. And I think we're going to watch the next 2 or 3 years where we will have oversight hearing after oversight hearing where different people across the political spectrum and ideological spectrum will present their case about where they think everything failed. And it's probably unfortunate because I think that we found ourselves in a much deeper problem than we should have been. There's every bit of evidence that if we could have followed the South Korea pattern or done things, akin to South Korea, that we could have avoided much of what's going on right now.
Yes, thank you, Professor. And I'm going to, Alexander Troy has had his hand up for a while, so I was going to give that individual a chance to ask a question. A reminder for all of our audience members, if we could try to keep our questions as brief as possible to make room for as many as possible. So Alexander, you should be able to talk at this point.
Can you hear me?
Yes, we can hear you.
So, Doctor, my question is there a metric or rule of thumb that you would look to that would enable us to relax the lockdown and let the economy, function again?
Yeah, so my advice on this is that the first step is to watch new cases fall off a little bit. You're going to then see, even when new cases fall off, you may still see hospitalizations continuing to track at least flat or even a little higher for a while as a lot of cases progress to severity. And then you're waiting. The next thing you want to watch for is to see hospital capacity open up again. So right now, as you know, in New York, you have a lot of field hospitals. You have makeshift ICUs in hospitals that never had such big ICUs and so on. And so we're completely overwhelming the system in New York. And quite frankly, even in cities and states that have absolutely perfect ventilator and ICU capacity, they don't have the personnel capacity to manage this. And that's something I think people are misunderstanding. It's not just about whether you have the beds, it's whether you have the personnel to manage this. So you're going to watch, first of all, to see hospitals get overwhelmed, and then you want to watch them loosen up capacity, free up beds. When you start to see the field hospitals closing down or being underutilized, I think that's the moment where you could start to talk about what type of measures can you relax slowly. And if you don't have adequate lab testing, and at that point, maybe even antibody lab testing, to give you confidence that a large percent of the population has already been exposed and has antibodies, then you're going to have to rely on small step measures to relax our lockdown. And those might be allowing certain types of workers to go back to work, allowing people to roam freely on the streets, but not allowing people to convene more than 2 or let's say even 5 in a room, and do very, very aggressive testing and contact tracing. If you could guarantee that you have the outbreak down to a sufficient level that you can aggressively test the way they've done in South Korea, you can open things back up. Just watch South Korea right now where they are opening things up. I think the schools are opening next week. Look at how they're managing. They do not have this 100% under control. They still have 20, 30 cases a day in Seoul. They still have more than that in Daegu. They're importing 40, 50 cases every day through travelers, and they know it. And so they're testing travelers aggressively, forcing them to quarantine. They test people multiple times. That is the formula to be able to loosen up your lockdown. Aggressive testing, get things under control in your healthcare system, and do contact tracing.
Thank you.
A couple of the viewers want to know about the idea of a second wave of coronavirus coming back in the fall. And because a lot of people listening are students, they want to know if we'll be back on campus in August. So what is your speculation, and what does the data and the science suggest about a second wave of the virus coming back when the weather gets colder?
Yeah, so it's not just the weather getting colder. I think the weather getting colder would probably have an impact on that. It's not, I think that's a reasonable part of the hypothesis, but we already know that warm weather is not really protective. We see massive outbreaks in places like Malaysia or Australia where it's summer right now, a lot of sort of equatorial areas. So we know that warmth doesn't really stop the virus, but it probably slows the spread somewhat, both because social distancing is easier, people aren't in small places as often, and probably because of the way particles are in hot and humid air versus in dry and cool air. So those are things that I think are worth remembering. The bigger factor is what happens when you remove your social distancing measures. What happens when you start to ease up and allow people to go to concerts or go to summer camps and then return from summer camps? And those are the things that I think are much more concerning. I would say that, again, if you look at South Korea, you will see that they have never stopped the outbreak. There are cases there every day. There were 101 cases there today, and they're in many, many cities. And so it's not like we're going to ever get this 100% under control. But with contact tracing, with testing, and with some degree of social distancing, we can get it under control. One could imagine a scenario where even a place like Yale University could invite students back to campus and have them self-quarantine for 10 days or maybe less, maybe a little more, in their rooms, with testing done at the same time, with them seeing classes on Zoom for 10 days, and then knowing that once we've done the aggressive testing, we're bringing them back into one area, that we could then allow them to continue to work within the community of Yale. And then maybe you don't have a fall break and you don't have a Thanksgiving break, because those are opportunities for more spread to happen again. So there are ways that one can imagine mitigating this if you sort of have much more evidence at that point.
Great. Thank you, Professor. I was going to open up another live question. Abby Nelson, I think you should be able to talk now. Abby's muted, I can see. So Abby, you might want to unmute yourself.
Okay, is that better now?
Yes.
Good. A couple of short questions. Can you get the virus again, or once you have immunity, are you prevented from ever acquiring another bout of this virus? Is the virus killed by ultraviolet light, by heat, by cold? And if you could explain the huge disparity in death rates. I looked in Israel and Germany, it's around 0.5%. In Italy, it's 11%. In the US, it's around 2%. These are all advanced countries. I'm surprised that there's such a wide disparity in the death rate.
All right, let me try to remember all of your questions, though.
The first was on immunity.
Yeah. So the first question is about a reinfection and immunity. And again, we don't know the answers to most of these questions. So everything I'm saying is sort of speculation to some degree, but the evidence that we do have suggests that you probably can't get the virus again. There are anecdotal cases of people representing with infection, and the reason why that has happened is, or at least that I speculate it has happened, is that the test is not a perfectly sensitive test. It probably has anywhere between 50 and 80% sensitivity. And the way we've used that test typically is you test positive because the specificity is high, so now you have COVID, and then we test you again 2 consecutive times when you're recovering, and if there are 2 consecutive negative tests, and in some places it's been 3, we then say that you're cured and you're no longer shedding virus. In some cases, people have represented after that with infection where they've tested positive. It's very possible that they had false negatives during those 2 or 3 tests in the interval. It's also possible that they just had progression of disease during that time. If there is reinfection, it's probably a relatively low amount. And most of us believe that you probably have immunity to this virus right now once you've had it once. That does not mean, however, that you would be immune to it in the future when viruses may mutate in the same way the flu virus mutates year after year. So we can't guarantee that there would be permanent immunity, but we could hope that a future vaccine will give us more and more immunity. And whatever immunity you have to this version will probably give you some comparative immunity to a future mutation. Your second point was about what kills it. There are many investigations that are going on right now trying to figure out what can kill this virus, including ultraviolet light, and other things. We don't know for sure exactly what it is. And I know of many trials. I know of some of my former students that are involved in some of those trials, particularly from entrepreneurial things. And now I'm forgetting your third question.
Well, it was also whether heat and cold can affect the virus?
So it definitely, we do believe it probably if it affects infectivity and how it spreads, but whether it actually kills it or not is unlikely.
The last question was on the disparity of death rates among the different countries.
Yeah. So that's a good question. So the disparity in death rates probably reflects the type of case finding you're seeing in different countries. In Germany and Israel, they're doing very aggressive testing of early stage individuals who present with either mild symptoms or no symptoms in the case of contact tracing. And therefore, those individuals are unlikely to die anytime soon. And so in Germany, the crude case fatality rate has now crept up above 1%, but up until a few days ago, it was like 0.5%. South Korea, as of 3 weeks ago, had a crude case fatality rate of 0.7. It's now 1.7 and will continue creeping up over time. In Italy, the case fatality rate is almost 12% right now, because as you can imagine, when you have an overwhelming epidemic and a limited number of tests, your first priority is to test only the sickest, and you're not even doing any contact tracing. You're not even doing any testing of very mild individuals or people that are minimally symptomatic. You're only testing people who are presenting with severe shortness of breath, and you're trying to quickly figure out, is this a bacterial pneumonia? Is it a COVID pneumonia? Is it acute respiratory distress syndrome of another reason? Is it organizing pneumonia of another reason? And one of the ways you can do that is by testing. And so when you test, you find you're going to end up having a very high case fatality rate.
Thank you.
A bunch of people want to know about the numbers coming out of China now, and China has started to reopen a lot of their economy, and the market where the virus started is now apparently opened once again. So could you talk a little bit about the data? I know it seems that the US intelligence agencies determined that this data, not to many people's surprise, is doctored. And secondly, the fact that they're opening up, is this a giant mistake, or is it a sign that this actually could come to a close sooner than we expected?
Yeah, from what I've heard from people who are on the ground there, or at least communicating back to us, it sounds to me they're opening up very, very, very slowly. They have the ability to open up a business there and watch it lose money for a while. And so you're seeing it's far from opening things up in a big way. It's what I would call a very gentle relaxation of social distancing. There's no evidence that people are going to concerts and so on. And when you look at Korea, which is obviously very different, their norms of returning to normal are still extreme social distancing. So that's number one. Whether we can trust their data or not, I personally think it's hard to trust anybody's data, and hard enough to want to trust an authoritarian regime. So I tend not to trust it. I will tell you in a sort of skeptical way, I don't trust our data either. And it's not because I think the federal government is suppressing anything, but I think that state governments have incentives to under-test, under-identify, and not necessarily do everything they can to identify. So I think it's good to look in the mirror and realize we're not perfect either. But I do agree the history of China and their ability to change narratives, change data to suit themselves should make us suspect.
Thank you. We have another audio question from Jamil. So Jamil, we should be able to hear you.
Hello, can you hear me?
We can hear you.
Yeah, hey, Professor Forman. My question was, how long do you think it'll take for us to understand the virus? I know there's new information like often coming out, how asymptomatic people can spread it. I think that was refuted recently. And, there's been information about, it being not airborne, but, some people are refuting that as well. How long do you think it'll take for us to fully understand the virus?
A long time. I mean, I think that we're going to continue to be dealing with mixed messages. I would point out that when HIV was sort of introduced into our understanding in like 1982, 83, or whenever that was, it took us years to understand everything we needed to know about that. I think it's going to be years before we fully understand everything we should. To your point about how it spread, we think that droplets are a key way of transmitting it, but there's certainly some people, very thoughtful people, that are convinced that aerosol contributes to that as well. So we don't have a firm answer on that. We do think that there is asymptomatic spread. Without a doubt, there's asymptomatic spread. It's one of the most concerning aspects of it, because if somebody is infected, has absolutely no symptoms, and is yet at work spreading it to somebody else, that's a concern. That's another reason why masks might be helpful.
Okay, thank you.
Thank you, Jamil.
So one audience member wants to know about the disinfection procedures that are going on in other countries where streets are being sprayed, stuff like that. Is that effective? And are we going to be seeing that in the US anytime soon?
I don't have a good answer to that. I mean, I tend to think that, I tend to feel like if it was rampantly spreading so easily because of surfaces of roads and streets and things like that, that everybody would have it all at once and we would not even be having this conversation. On the other hand, until you can show me antibody testing or wide-scale PCR testing that can tell us what the overall prevalence of exposure has been, anything's possible. So I don't want to be dismissive of what any measures that anybody has taken.
Professor Forman, I was curious, this isn't coming from the audience, but as someone who is part of the public health leadership at Yale, involved in the School of Medicine, the School of Management, the School of Public Health, I'm curious, there's been a lot of news recently, and I know students have been engaged about the relationship between Yale and New Haven in this crisis, and the question of whether or not Yale was doing enough, and now Yale is opening up beds in the residential colleges for first responders. What is your impression of how that has played out? And are we in a good place right now as far as the relationship between our institution and then New Haven in general, as far as making sure that as many people as possible get treated?
Yeah, I have only as much information as you do on the topic of Yale University and how it's working with the community. I do have other information just from my experience with the hospital and how they're dealing with it. I'll tell you a few things, most of which I shared with my class this morning, which I think are relevant. One is that I think I don't know the conversation that occurred between President Salovey and Mayor Elicker, but it strikes me that it would have been almost impossible to rapidly open up the colleges to any outsiders. It also strikes me that the university from day one made an extraordinary effort to open up space in Payne Whitney Gym and be prepared at great expense to make certain that we would be ready to take on a large number of individuals as they came through. It also should be noted, as far as I know, again, this could be wrong, but my understanding is that the Omni Hotel shut down. Initially, early in this, we were going to be sending a lot of our healthcare professionals to the Omni so that they would not go home and potentially infect their own family members. And that worked for a little bit of time. And then the Omni shut down. So it's not easy to rely on all private actors to solve these problems all at once. I think, from my understanding, I think that cleaning out the dormitories on a very short notice, cleaning out the colleges on a very short notice, and accommodating our first responders, fire department, and police is a priority, but I'm not sure that it could be done any faster than what is being done. I have personally been so impressed by the responsiveness of the hospital leadership, the medical school leadership, the Yale Health Plan leadership during this time. And while I've not talked to or heard directly from President Salovey, I have every belief that he has been at the top of the pyramid making a lot of those decisions. This is such an extraordinary time that I think most people do not appreciate that, a hospital like Yale New Haven Hospital, a health plan like Yale, has invested tens of millions of dollars in something that will never pay anything back. This is not where you're doing it because you're going to make money off of it. This is where the goal is completely about the public's health, about healthcare in the community and doing what's right for the community at extraordinary expense to these private institutions, Yale and Yale New Haven Hospital among them, at a time of enormous duress. So, I'm the first to criticize private actors when I think they fail. I think in this case, I think we've done a very good job. I've been impressed with what Yale has done, and I think all of you should be equally proud.
Thank
you. One student wants to know about the WHO's response and the future of the WHO after this pandemic. So were they not aggressive enough when reports first came out of China? And how much blame can you put on an institution like the WHO? And how could it be reformed in the future to prevent further crises?
From my view, and it's a very narrow view because I'm not a global healthcare person. I've done very little work with global health institutions. And so my familiarity with the World Health Organization and others is limited. From my point of view, having sort of come to this relatively late, I think they've done a very good job. They stood up testing kits from most parts of the world that worked reasonably well, if not very well. They seem to have been engaged and wanted to engage us very early on. I'm sure that in retrospect, everybody was late. Everybody was late. I'm sure at the beginning, everybody looked and said, oh, it's just China, and China is an emerging economy, and they don't have good, hygienic practices, and that's why it spread. People come up with all different reasons why this was probably just a China problem. And then when it was a South Korea problem, it got a little more scary, but people said, oh, it's not really a South Korea problem. It was only a religious sect, and that's how it all happened, and that's a separate issue. And then as it continued to spread into northern Italy and Iran, and then Spain, and now in the United States and New York, I think it comes to the realization that this is not a unique problem for any one part of the world. This was a major problem for the entire world. And I think what's frustrating for people like me right now are that there are some rural parts of our country that still think that this is just an urban problem and not a rural problem. And to me, that's the type of hubris that we can do without right now.
Thank you, Professor. Another question we had that was written down to us was back in February, Yale professor Edward Kaplan recommended giving the flu vaccine to everyone in the US. And a quote from him, he said, quote, to reduce the number of false positive COVID-19 cases reported, since fewer people would have the common symptoms of both flu and COVID. And if a vaccinated person did get sick, it would raise the probability that the case is coronavirus as opposed to flu, and make it more likely that said person would seek care. Why isn't this common sense procedure being followed in the US is the question.
Yeah, let me first say that, I think Ed Kaplan is one of the 5 smartest people at Yale, and I won't tell you who the other 4 were because it would offend thousands of others. But Ed Kaplan is the person I referenced before when talking about how we could tamp this down effectively, and he has done mathematical modeling of how to do that, and he has done the modeling behind HIV needle exchange. He's done the mathematical modeling between smallpox detection and treatment if we would have had a biological attack. Anthrax, he's done a lot of work. And so Ed Kaplan is a really bright man. And I think his suggestion about flu vaccination is the right one. And I don't remember, I thought the number was 51%, but then yesterday on some televised program, I saw a number of 40%, but somewhere around 50% of the population gets vaccinated with the flu vaccine every year. It's a highly effective vaccine, even when it's ineffective. And it really helps us a lot to discriminate between different types of illnesses. So it's also very cheap in the big picture. So I would say that one of the strategies that we have to have in the future is to do much better with flu vaccination. As you know, this is another sort of area where libertarians and others come into conflict about vaccination policies, and we do not have mandatory vaccinations for adults as we do for school-aged children. But it is something where I think through education and through better guidance, we would do well to address flu vaccination, even going forward, even during this time right now.
Thank you. we're going to have another audio question here from Alexandra. Alexandra, we should be able to hear you.
Yes, I had a question about the vaccine. There are some theories that this will go on until there is a vaccine that has been tested and can be widely distributed. One theory is that this is 18 to 24 months out. However, there have been a lot of the red taping and prior sort of safety checks have been eliminated to expedite this process. I was wondering if you could speak to the risks of this and what the sort of time frame realistically looks like in the safest way.
Yeah, so I'm probably in the camp that believes that the FDA has good leadership and will make good decisions about proceeding through phase 1, phase 2, and phase 3 trials. We'll use the best evidence and will hopefully not introduce a vaccine that is unsafe and certainly hopefully is at least somewhat effective, if not very effective. But even under those circumstances, I think we're looking at 9 to 12 more months because we only are sort of entering the earliest phase of trials right now. And it does take time. And remember, it's not just getting through the FDA process and testing the vaccine. It's also about scaling up capacity to manufacture the vaccine and then distribute and give it to people across the country. So, and again, seeing how much we failed with testing makes you remember how important it will be to figure out how you can do mass vaccinations, because even if we can scale up and get 100 million vaccinations ready for next January, let's say optimistically, you still have to figure out how you can do a mass vaccination program when you weren't able to administer more than 100,000 tests a day right now.
Thank you. So some of the audience members want to know about the vaccine. So what does a vaccine approval process look like? What's it going to look like in this situation? And the number that people are throwing around is 12 to 18 months. Is there any possibility of a vaccine sooner than that?
Yeah, so that's what I was saying. I think 9 months, 12 months is probably the absolutely shortest it can be. Even the most optimistic officials, other than our president within the administration, have never suggested anything shorter than that. And I think I probably have a naive optimism about it because I've not been directly involved in what it would take to get through a phase 3 trial, get the data together, analyze the data, and then get the approval. And that assumes that everything goes right. That assumes that every vaccine development that's going on right now will somehow work out, and then at least one of them will lead to a successful product. So I think that's where we're really at right now. You have to go through all the phases of testing it in healthy people, testing it in individuals that are at risk, watching them over time, seeing what the outcomes are, seeing the effect, making sure there's no untoward effects.
Thank you, Professor. I think this will probably be our last question. We have David Anderson with his hand up. So David, we should be able to hear you. You're going to need to unmute yourself, David. We can't hear you.
Sorry, Dr. Forman, you talked a lot about the need for much more extensive testing, contract tracing, and so forth, and that would provide us with the quickest way out of the epidemic. But what is the evidence that we're actually taking those actions and that's happening? If not, why not?
Yeah, so there's two components to that. One is the actual testing, and there I think the evidence is there. I mean, I can check right now and just see, but every day, as I mentioned before, there's a organization that basically reports on their testing capacity in the United States. And it'll probably be too difficult for me to try to do this all at once, but actually here it is. So every day we get some type of update on what, now we don't have today's update yet, but yesterday we did 98,000 tests as far as we could tell. We're hoping that number will accelerate. I think the Abbott Labs test is supposed to provide us with about 50,000 tests a day capacity, and that can also scale up. We're also seeing private labs scaling up. It seems that some of the limiting factors are reagents and even swabs, which are the simplest things seemingly to manufacture. So I do think we're accelerating our ability to test. Then we need to be able to do the contact tracing, and contact tracing is almost impossible at this stage when you have a massive outbreak. That we need to be able to put together, and this is what our epidemiology intelligence service for the CDC will do, and our departments of public health, both at the state and local level, will do, but to be able to set up groups that can go out and actively trace every new case when we get it down to a smoldering level as opposed to the peak level we're at right now. I'm always sort of the optimist about where we're going to go with this. And so I'm hoping that over the next few weeks, we're going to rise to the occasion and we're finally going to be able to test adequately. I will point out that one of my earliest sort of tweets about this 5 weeks ago was that I was heartened by the fact that we were going to be testing aggressively very soon, and we should not be surprised to see an explosion in new cases. And I think I was about 2.5 weeks behind in that. In my optimism, I think we really failed for a long time to even get the minimally adequate testing.
Well, it seems like contact tracing would be doable in those communities that haven't yet been hard hit by the virus. You talk about the Midwest and some of those communities. Should those communities be aggressive about trying to create that kind of process?
Yeah, I mean, I will tell you that I'm less optimistic than you are. I think that they already have such wide outbreaks. It's just that the severe cases are so small that you're only seeing small numbers. But in some of the most rural areas, we're seeing, fairly widespread outbreaks. We're just not testing for it. So I think that we'd have a hard time. But yes, you're absolutely right that if we could find areas that are really unaffected, there's one county in New York State right now that seemingly doesn't have cases. That would be a great experimental case to do widespread quick testing and find out if there are any cases there. I'm sure there are, and then do contact tracing and tamp it down.
Thank you.
Well, it's now just after 5:30. So on behalf of everybody listening and on behalf of Kobe and our whole program, I want to thank you, Dr. Forman, for joining us today, taking the time out of, what I'm sure is a busy schedule, classes and the research that you're doing, for joining us and talking about this important issue. And we just want to wish everybody well, hope everybody is staying healthy, and we hope to see everybody back on campus in the fall.
Absolutely. All right. Good luck.
Thank you, Doctor.
Thank you,
Take
Doctor.
care. Bye-bye.